Okay, welcome to IISE transaction webinar series. My name is Yuding. I'm the editor-in-chief of IISE transaction. I'm on faculty of Texas A&M University. And IISE transaction webinar series in fall 2022 features 7 talks based on the respective articles to be published in the special issue of the journal. And the special issue is going to appear in print as the first issue of 2023. Today is our first webinar in the series, and we are delighted to have Dr. Brian Denton with us. Dr. Denton is a Stephen Pollack Professor and Chair of Industrial and Operations Engineering at the University of Michigan. Prior to Michigan, Dr. Denton worked at IBM, Mayo Clinic, and his state. Dr. Denton is a fellow of IISE and Informs, and a past president of Informs too. Dr. Denton is a leading expert in developing and applying IEOR methodologies in healthcare application. His work was recognized by a long list of honors and awards, and I'm going to skip that detail, but before we are setting up the webinar, and Dr. Denton and I was talking about one of his paper was the top 10 most downloaded paper in IISE transaction from 2005-2010. That is awesome. His work also being a finalist for the 2012 Informs Daniel Wagner Prize for Excellence in OR Practice. So today, Dr. Denton is going to speak to us about the frontier of medical decision-making in the age of data analytics. So the platform is yours, Brian, and whenever you are ready.
Thanks, you. Yeah, I really appreciate the opportunity to write this invited paper. The paper that this talk is based on. It stretched me out of my comfort zone into areas that I think are very important. And so my goal is, I guess, to try to infect some of you with some interest in potentially working in some of these areas. I'll also say this is a bit of an atypical talk for me. Usually I talk about a research project and try to answer some research questions. This is probably a talk that generates more questions than answers. And so I hope there's something for everybody here. And there'll be time for Q&A at the end, certainly. And feel free to chime in with questions or comments or thoughts in the chat. I'm going to rely on you, Ding, to help me keep track of the chat because I'm not great at multitasking. So let's get started. Oh, and if I should have mentioned too, these slides are available on my website. If you're quick with your phone, you can snap up the QR code and follow along if you like. And if you're interested in the paper this is based on, just let me know and I'll be happy to send it to you. I think it's going to become open access at some point, but if it's not already, then just let me know and I'm very happy to share it. So yeah, let's jump in with a couple of things that I want to start us with. First, a lot of the work I do is around chronic diseases. So these are things like cancer, diabetes, kidney disease, heart disease, and others. And this reflects to some degree my bias. I'm interested in studying problems related to chronic diseases because these are diseases that unfold over time. And often, people live with for decades, and there are an enormous number of health interventions to try to prevent diseases. There's also new treatments, new devices coming online all the time. So this is a very active area of research, but that's not to say there aren't very exciting things working in infectious diseases, for example. You can all think of one that's been top of mind for a couple of years that's generated a lot of research. I also want to start just by talking about like the volume of research that's done in medicine. It's really shocking, actually, I think. These are results from a query of PubMed, probably the most comprehensive database for medicine. And so just in a 10-year period, there are over 1.4 million articles on cancer, and within that, close to 80,000 on prostate cancer. So that's a lot of reading if you're a oncologist, for example. Heart disease, also very large numbers, diabetes, kidney disease, and the list goes on. You see it getting a little bit smaller as the risks of the disease and the incidence of it change over time. So cancer, heart disease, and stroke, these are the leading causes of death in many countries. So not surprising. So I'm going to shift gears and show you a query that I constructed. I don't claim it's perfect, but I feel good about the trends and roughly the numbers we're seeing here. And so this is a search of PubMed, that same database, looking at it from a methodological point of view. And certainly there are other methods I could have included in here, but what do we see from this? Well, machine learning has obviously taken off. We're seeing a lot of activity in the medical literature. Things like simulation, stochastic models, decision analysis, they get used quite commonly in many different contexts. And I think that's exciting for people that are working in this area. There's also, and I'm going to pick on optimization here a little bit, very little done with optimization in the medical literature. Now there's some, one example would be intensity modulated radiation therapy. That's been, extraordinary application of various kinds of optimization methods to improve basically how radiation is delivered for patients with cancer. So that's one really nice shining example, but the examples are few and far between. And so there's a lot of opportunity, in all of these areas, and in some areas you can really, be the person that breaks new ground. So that's one of the messages I want to leave, especially for anybody who's earlier career and looking, for interesting problems to work on. I'm going to pick on optimization a little bit more, again, reflecting some of my bias, and point out that I think, while the optimization literature is incredibly rich, the work at the intersection of optimization and data analytics or statistics, if you like, is more limited than I think you would expect to see. And this is one of the reasons we're not seeing a lot of activity in the medical literature, in my view. And I just have like a generic formulation of an optimization problem here. I think I'm stating the obvious when I say that, these models only work if you have data to populate things like constraints and coefficients and right-hand sides and objective functions. But interestingly, when I think about all of my favorite optimization books, or almost all, some of them are actually right behind me here, they assume that you already have some data to start with and focus entirely on the optimization piece. And there's a lot of complexity, I would argue, around how you populate, these models with data. And we all know the expression garbage in, garbage out. So if your goal is to have impact in an area like medicine, or any area, you really have to think very carefully about this. And so there's many different challenges that exist when it comes to dealing with data. I listed a few here that are challenging things to deal with, and often aren't part of the discussion around optimization models, at least in the pedagogical framework. So I guess I would say the motivation for this webinar is based on the fact that there's an enormous amount of data that's been developed over time. And I'm going to focus quite a bit on observational data. So this is the kind of data that's just collected routinely when you go and enter into the health system. It's just growing at an extraordinary rate. And longitudinal data in particular is growing, amassing, opening doors for things like chronic diseases, where it's particularly important to be able to model, the progression of the disease over time and look at sequential decisions over years. And there's been a lot of research in this area, like in industrial engineering and operations research, a lot of exciting steps, especially in the last couple of decades, but not limited to that. And so my goal, I'm hoping, is to instill some interest potentially in some of you in thinking about problems at the intersection of IEOR, but also data analytics and medicine. There's just so many opportunities out there. And this is the paper at the bottom that describes some of these opportunities. So I may not get through everything today, but I hope to give you enough to get excited to maybe take a look at that paper or other people's papers that talk about some of these topics. And with that, I'll mention a few. This is by no means a comprehensive list, but these are a few articles that are related. They're review articles talking about various topics around healthcare. The first one by Wally Hopp et al. Is probably the most related to my paper. The other two I recommend as good ways to learn more. And I know there's more out there too. So please feel free to put in the chat, resources that any of you have found that you like that relate to this topic. But I want to acknowledge that there are some other great pieces of work out there. And so for the remainder of this presentation, I guess I'll try to hit a little bit on some of the different topics covered in the paper. The first one is, leveraging observational data. It's this resource that's developed. There's enormous amounts of it, but there are a lot of challenges that, you could change the word challenges to opportunities for research in this area. I'll talk a little bit about sequential decision-making and the role of human behavior or the lack thereof. There's not enough integration of human behavior into IEOR models, in my opinion, to be able to move them, into practice in medicine. And then I'll mention a few other opportunities that are out there. And I'll apologize in advance if I don't get to all of them. And I know you, Ding, will help keep me on time with this. But starting with observational data, for some of you, that might be a term like, what is that? So what I'm talking about when I say observational data, I'm not talking about randomized control trials. Those are the gold standard. There's fantastic data resources available, but they tend to be small samples, extremely costly to collect. Observational data, on the other hand, is collected as we all, move through a health system. It includes things like demographic data, insurance claims, pharmacy claims, lab test results, genetic data, generally the stuff that comes, from electronic health records as well. And when I started working in this area around 15 years ago, it was really challenging to find good data sets to work with, particularly longitudinal data. But that's all changed. Now many health systems are sitting on a wealth of data. There's a lot of claims data out there that you can get from Medicare and Medicaid. That's national data, so it's very comprehensive. The VA, is a national health system that has the ability to aggregate and create extraordinary research data sets, for a national population. But of course, that's a specific population. And so we have to worry about the potential biases that come with that, because it may not reflect the population in general. And I'm going to touch on that topic a few times over the course of this talk. Academic medical centers. I worked at Mayo Clinic early in my career, and one of the exciting things there was that they did have access to extraordinary data sets. But this is not only available to the Mayo Clinics of the world now. I mean, most academic medical centers are amassing fantastic resources for research. Here at Michigan Medicine, we were able to access literally, in some cases, decades of longitudinal data for patients with certain conditions or diseases to do research. Optum, some of you might have heard of. That's a company that is purchasing up data, from health insurers, from labs, trying to connect data to create a comprehensive view of the different patients that are out there. So I guarantee they have some of your data. Of course, they're very careful to anonymize it. Their whole business model relies on anonymizing it. And It's available, as I understand it, to academic medical centers on a cost recovery basis. So we have access to that here at Michigan Medicine. Probably a number of you on the call may have it, may not even know that your university has it. And then, of course, they also have a for-profit arm that's selling this data for people that are working on, practical problems, business problems. And then 23andMe, if you haven't checked that out, take a look. Genetic data, it's just extraordinary how much is being collected across the country. And when you start to link these things up, I'm not saying we're at this stage, but we're moving in the direction of having complete, like situational awareness of patients and the factors that are associated with their health, related to their health, and it's opening up some really, really extraordinary opportunities. So I mentioned challenges, and this just goes in a little bit more, like all of that data, it's all got some issues or challenges associated with it. I'll touch on a few. There's certainly unmeasured confounders, okay? Things like patient's environment, their social situation, many things that could affect how the decisions are made or how they make decisions about whether and when to see a provider or to have treatment or to take their medication on a daily basis. And so things are getting better, but those are always there. And so that's creating some important challenges and opportunities to use techniques from causal inference, for example, to try to enable the use of data. Censoring, people change health systems all the time now. It's very common. So you lose people to follow up. The fact that there's a very disaggregated health system in the US in particular means that it's not always easy to patch together the data. And then one that interests me a lot is the effects of measurement. Okay, so some of you know this as the Hawthorne effect. The idea that when you measure something, you may influence the measurements. I like to use Weight Watchers as an example. Like the idea of Weight Watchers is to make people aware of their weight over time and what they're eating over time, and that alone can have a substantial effect. So if I want to build a model to study the management of cholesterol treatment, for example, I might pull data from Michigan Medicine on patients who have had cholesterol tests and been treated. I want as much of that data as possible, in some sense, to build a model that I can validate. But on the other hand, those patients that are getting those cholesterol tests all the time may be very different than patients that are not getting those tests regularly, or patients without access to health care. And so I'm introducing a substantial bias into the model in that case. Then there's all kinds of missing data. I used to think missing data was just one thing, but I realized that missing completely at random is something that's not hard to deal with. Missing at random, meaning you could predict some of that missingness using covariates that you have. There's some ways to deal with that, and then missing not at random is maybe the most insidious of the challenges. And I'll admit that I'm still learning a lot about these issues myself. So what I want to do is kind of answer the who cares question. Maybe some of you who are here, were naive like me and thought, well, this stuff, these problems with data, they're like second or maybe third order effects, and who cares? Like we'll just use that observational data. It'll probably be good enough or better than not doing anything. And so this is a project that really opened my eyes to that some time ago, and in some ways has changed the way I think about research and optimization and the kinds of things that I like to do. That's really sent me down a somewhat different path. And so I'm hoping that this is an example that you can draw something from. So a lot of my research has involved looking at prostate cancer and the different kinds of diagnostic tests that are available, the various kinds of treatment, and thinking about how patients should navigate these over time. And so one piece of this, one particular piece, is related to imaging. Imaging is done for, or may be done for, patients that are newly diagnosed with prostate cancer. And that's done via a biopsy by a trained urologist. Once that's done, then there's a key question, which is, has that cancer spread outside of the prostate, or is it still confined to the prostate? And that's very important, because if it's confined, then surgery, for example, might be a cure. If it's spread, if it's metastasized, then you're looking at chemotherapy, for example. So these are two very popular kinds of imaging that are done. Bone scan, which you may not have heard of. I'm guessing almost everybody's heard of CT scans, and they're used to look for signs of metastases for patients, again, that have been diagnosed with a prostate cancer. And so the reason this is a kind of a tricky problem is, there's harms for not imaging and there's harms for imaging. Okay, so not imaging, the harm is that you might miss a metastatic cancer, and a patient might go for surgery like a radical prostatectomy, like the image here. That's major surgery that is not going to help somebody who has a cancer that's metastasized. Misdiagnoses, they also like I said, subject patients to things like surgery, and then delay getting like appropriate treatment for a metastatic cancer, like chemotherapy or some of the other treatments you hear about in the news. So that's the not imaging, but then there's harms of imaging too. So there's harmful radiation that comes with CT. That's probably one of the lesser concerns, but still a concern. Incidental findings, they occur all the time when a radiologist sees something suspicious, like in a bone scan, for example. Then the patient might be recommended for a bone biopsy, very painful, anxiety causing. And then other things like just blocking access, gumming up the healthcare system with patients that aren't benefiting from imaging is a problem from a cost point of view and also a patient access point of view. And so Choosing Wisely is a campaign from a foundation working in internal medicine to try to reduce the amount of imaging, because there's a belief that imaging was used much too much in the past, and that it's a problem and causing more harm than good. So you're sort of damned if you do and you're damned if you don't. Who do you image? And the real question is that who do you image? Imaging everybody or imaging nobody doesn't, those don't make sense. So this is a project that some of my research group worked on with a number of collaborators and also patients that are part of a collaborative called the Michigan Urological Surgery Improvement Collaborative. You have to love that acronym, music. And it's a collaborative that's been going on in Michigan for some time now. There's more than a dozen of these in Michigan, and a lot of states are starting to see these develop. These are quality improvement collaboratives. They're in music's case physician-led and include almost all of the urologists in the entire state. If you look at the this is called the Upper Peninsula or the UP, and it even includes folks all the way up there, all over the state of Michigan. And so it's very comprehensive data. Almost every man in Michigan who's diagnosed with prostate cancer, has their data stored in this central database, again, anonymized, and used very carefully, but an extraordinary and really rich source of data. So I and my research group were really excited when we found the opportunity to collaborate and to dig into some of this. So some of the things, I said it's more about who you image. And so we started to think about different risk factors for or associated with having a positive bone scan or a positive CT. And we wanted to build models that could evaluate guidelines or predict which patients would benefit most from imaging on the basis of predicting which patients, would have a positive imaging test if they were to be recommended for imaging. And so some of these things, race and ethnicity, biomarkers, tumor stage, Gleason score, you probably may not have heard of. It's a scoring system that pathologists use essentially to rate the aggressiveness of a cancer. And then other pathology information related to what comes out of the biopsy, which is how the patient got diagnosed in the first place. So these are some of the different kinds of factors. And so here's where the challenge comes in. Even though there's complete data for almost complete data for all men with prostate cancer in the state of Michigan, there are, going to be patients that have metastatic cancer and ones that don't. And there are patients who have imaging tests and patients who don't. Okay, so this is all pre, modeling and trying to be selective about who will benefit from imaging. So I sometimes call it the Wild West. Urologists were doing what they thought was the right thing to do, and they're probably getting it right a lot of the time. And so if you look at the entire population, and then you separate it into the group that have had imaging tests, the ones we have data on, they're going to be overexpressed in terms of patients that have metastatic cancer, because there's a reason, they got imaging. Doctors recommend people for tests when they think it's going to benefit them, when they think there'll be some useful information that comes from it, versus those patients that don't get imaging, where there's, that's a lower risk group. And so this is the crux of a problem, a verification bias. We only have that outcome information or those labels for patients that got imaged. And so the first thing that we wanted to do in this study was to evaluate some of the existing clinical guidelines that are out there that define who should get imaged and who shouldn't. And you might think, well, if the guidelines exist, why do you have to bother with this stuff? But there's many guidelines, a lot more than I show here, and they don't all agree. And this is true of everything in medicine for the most part. All the interesting problems, there's just disagreement about what the right thing to do is. So I'm showing you a few guidelines. EAU, that's the European Association of Urology. AUA is the American Urology Association. NCCN is our National Comprehensive Cancer Network, and so on. And so what we did was compute sensitivity and specificity. And some of you are familiar with that. Some of you probably aren't. But you can relate these to like type 1 and type 2 error in statistics. And so I put some definitions at the bottom. So sensitivity would be the probability a test is positive given a disease is present. And specificity is the probability a test is negative given the disease is not present. So we want these to be, close to 1, ideally, to be able to assert that we have a good test. And so I'm using the word test, but in this case, we want to evaluate guidelines. And so the guidelines, basically, they're rules that depend on factors like biomarkers and pathology information. So you can think of it as a very simple test. You collect that information for a patient. If they fall into the category of being recommended for imaging, then you can think of that as the test being positive. If they don't, then the test is negative. And again, we'd like to send people for tests that have the disease, and so we want sensitivity to be high, and we want to avoid those imaging tests for patients who don't have the disease. Okay, so what we get, and so this is basically a very naive approach. I'll focus in on the AUA, just because that's the American Urology Association guideline. So we might think that's most relevant to music. And if we compute sensitivity and specificity based on the original data, So this is the data for patients whom we have imaging results. We get incredibly high sensitivity and incredibly low specificity. And the point I want to make is that that verification bias has completely disrupted the data there. So if we correct for bias, we get very, very different results. And these results are much closer to the truth. Okay, so if we didn't do this, we would be trying to we think we're informed and making a decision, but based on sensitivity and specificity data that is completely different than the reality. So where do we go from here? Well, good thing we did some bias correction. And I'm just going to talk about this one example. And if you're interested in learning more, I really recommend this paper by Begg and Greens on how to deal with verification bias or selection bias. The idea here is, and so I've switched T to G to represent that G stands for guideline. And so G plus means the guideline recommends a patient for imaging. Okay, and so the sensitivity for the guideline is, the probability that the guideline's positive, given that the disease is actually present. Now, if we only compute that based on the patients who have been imaged, then that's a problem. That's going to lead to these spurious results. But if you apply, Bayes' theorem, and this is the idea that Begg and Greens, demonstrate in their paper, you can start to express this into terms that you can get unbiased estimates for using the entire population. So the probability that the disease is present, given the guideline is positive, the probability of the guideline is positive, we can compute that with the entire population. The probability the disease is present, we can use the law of total probability to break this up and conditioning on positive guideline or a negative guideline, and we can get unbiased or less biased results for sensitivity by doing that. And so similar kind of idea with specificity, really same idea, to estimate the specificity and get better estimates. Now, this doesn't come for free. Of course, there are some assumptions in here. One assumption is that the data is missing at random. Okay, and I don't mean completely at random. If the data, if people were randomized to imaging and non-imaging, we wouldn't have to worry about any of this stuff as long as we had a reasonable sample size. But missing at random, means that missingness is predictable in terms like using covariates that are available. And so essentially we're assuming that, the factors that are considered by the guideline, or the factors we have available to us in our data set are only those factors that influence imaging decisions. Seems fairly reasonable when you have a comprehensive data set, but it's not perfect. Of course, there could be other factors like, some patients may talk to their next door neighbor about what they did when they had dealt with a similar situation, or someone in their family, for example. We're not capturing some of those unmeasured confounders. So I just want to mention, just put in a plug for the paper that covers some of this. We wanted to do more than just measure existing guidelines. That was important, but we also wanted to try to optimize guidelines that could trade off between the harms and the benefits of imaging. And I'm not going to go through all the notation, but for those of you who are interested in machine learning, we looked at an approach to try to optimize classifier. And again, we have to think about those patients who have missing data. If we ignore them, we're going to end up with a classifier that is very biased. And so what you're seeing here is some of you might recognize like the logistic loss function in the first two terms, but there's a delta here. And so the delta represents some number between 0 and 1 that we use to weight the different possible outcomes. So one outcome is missing metastatic cancer. Another would be like imaging people who don't have metastatic cancer. But these outcomes are really not, the same. Most people would put much higher weight, higher delta, because missing a metastatic cancer has much greater health impact. Then there's other things like, regularization term, and then an approach based on using a graph Laplacian to extract information for unimaged patients. And the easiest way I could describe this, and there's more details in the paper, in an original paper by Belkin from 2006, but you can think of it sort of like K nearest neighbors. Okay, so if we were to look at a graph, in the space of the different risk factors that exist, we can learn something from those unimaged patients based on the nearest neighbors, those patients that have similar risk factors and who were imaged. Okay, and so we did that. We tried optimizing guidelines. This is a figure that you'll find in that paper I mentioned. And what we did was we used that approach, and we used a number of other approaches too, like popular ones like AdaBoost and random forests, to construct guidelines that are non-dominated in terms of sensitivity and specificity. And I'm showing you not sensitivity and specificity, but I'm showing you what we actually, showed to the urologists that we were talking to, and the patients that we were talking to. These are factors that are, related. You can translate sensitivity and specificity into these, but they're the percentage of patients with a missed metastatic cancer, and then the number of negative studies, and you could change studies to imaging tests. So the number of negative imaging tests, like the number that we would have, these are tests that we would prefer not to have done if we were clairvoyant and knew what the outcome would be. So you see this really long trade-off. Acceptable risk was defined at about 1%. There's actually an enormous amount of discussion among the urologists in music and feedback from patients. The numbers varied from like 1 to 5%, but the most conservative was adopted. And even that, you can see, reduces the number of negative studies substantially. And so these models were implemented in music, and there's a paper that's referenced in the OR paper I mentioned that talks about the resulting outcomes when this was implemented in practice, which were essentially to reduce the amount of imaging without impacting the detection rate. So you can think of that as getting rid of the imaging tests that were causing harm instead of good. That's a very kind of quick approach, but I encourage you to take a look at that paper or reach out if you want me to learn more about that. Wow, feels like I'm moving fast and I still have a long way to go. So let's see. Maybe I'll pause there and see if anybody has any questions before I move on. And if not, that's totally fine. I'll try to leave some time at the end, and you, Ding, please keep me honest on the time, so we do have some time for Q&A at the end. Yeah.
Well, one of the benefit of a webinar is we do have a little bit kind of flexibility, because we don't have to empty the room by the hour. But I understand everyone is busy; they probably only allocate an hour. So if you can probably leave about 5 to 10 minutes to the end, and I see you still have additional 3 topics to cover. So if we can do that a little bit faster.
Yeah, and I'll go through these in much less detail, just trying to spark enough interest that some people decide to learn a little bit more about this. So I spent a lot of time talking about observational data, extraordinary resource that you have to be very, very, very careful with. Sequential decision making. So this is an area that I'm personally very interested in, and so that bias is reflected in the paper. It's also something that's fundamentally part of chronic diseases and prevention and treatment of them. And to my way of thinking, you can break these into two different approaches. So there's model-based approaches, like Markov decision processes, and there are many variants, of those, and stochastic programs, particularly multi-stage stochastic programs. And I would describe the idea of this as formulating a model, estimating the parameters, using historical data, solving for a policy, that recommends a particular action for every state of the system, and then presumably implementing that policy. Model-free methods I would put under the umbrella of reinforcement learning. Now, I would say they're not totally model-free in the sense that you have a set of, for example, states and actions in mind, but unlike the model-based case, we don't have an estimate of transition probabilities, for example, for an underlying Markov chain. Those are going to be learned in this case of model-free methods. So when I say formulate a model, I mean sort of much less specific than, or at least the goal is not to estimate those parameters, from historical data, but to learn over time. Okay, and this is very different. It involves interacting, with the system. In this case, a medical system, and the topic of exploration versus exploitation is quite fundamental to these approaches. Some of you may be familiar with like Q-learning or temporal difference learning, and these are methods that have convergence guarantees in theory, asymptotically, but the exploration aspect is important, and that's particularly challenging in medicine where the stakes are very high. So, randomly trying different policies, for example, that's something that, to get that through an IRB, for instance, would be very challenging. So one of the examples I'll just give you is around prostate cancer and active surveillance of prostate cancer. So this is an area I've done lots of work in. Again, reflecting my bias, I'm using examples from my own research, but the idea here is that, we have this sequential process. We have a latent Markov model or a hidden Markov model, if you like. This is in the model-based context, so we need to estimate this. And for this particular model, there's two states that are unobservable. One is a low risk prostate cancer state, and the other is a high risk prostate cancer state. Patients in the low risk state, the recommendation is that they are surveilled over time, and then if they enter the high risk state over here, then they should move on to more definitive treatment because they're at risk, serious risk for metastatic cancer. So from that, latent Markov model, we can get a updated belief that a decision maker, like a urologist, could use. Okay, so this is the belief is going to tell us the probability that the patient is in one state or the other, and so if the probability of being in the high risk state gets large enough, then some action will be taken. And in this case, there's biomarker tests that are done. They're very non-invasive, so those are done routinely, and they help to update the belief over time. But another decision is whether to do a biopsy, and that's much more substantial, much greater impact on the patient, certainly something that anyone would want to avoid if it wasn't going to provide helpful information. So that's the key decision that's made here. If we want to optimize, then we think of there being rewards. That's a weird term to use, but there'd be a negative reward for the impact of biopsy on quality of life, and also it might be better to refer to it as sort of cost in quotes here. So there's a cost of harm from biopsy, and there's a cost of delayed detection of a high risk cancer because you're putting the patient at risk. And so we've used like a weighted reward function for some of the studies that we've done. And then you go to the next time period, update the model. So some transition occurs, some observations are collected, you get an updated belief, and you move on from there. So this is a basic partially observable markup decision process if you start to lean towards looking at the optimization aspect of things. And the point I want to leave you with here is that, so we use data from a number of different studies. The Movember Foundation, some of you might have heard of, that's the foundation that encourages people to grow beards, and November to raise money for prostate cancer. They have collected up and amassed data for dozens of active surveillance studies around the world. And so we were able to get access to that data and use it. And we're primarily interested in a couple of different things, like the low-risk cancer state and the high-risk cancer state. But there's a lot that's going on in this observational data. So, there's patients that are leaving active surveillance with treatment with low-risk cancer. So they're doing something that they're not recommended to do, but of course that's up to them. You can't stop patients from doing that. They're leaving active surveillance without treatment, so they're disappearing from follow-up, or they're leaving active surveillance with treatment for high risk. And if you ignore these states, you're ignoring a lot of the information that's available. We could have a single state that just says they disappear, but that would impact our estimates of these things like A11, A12, A22 that we're very interested in. And so that was something that, we would have gotten a completely distorted picture of the underlying model, and then the policies we generated from it would have been, something we couldn't trust at all. So that's one more example. If you're interested in partially observable Markov decision processes, they're basically MDPs, but with a continuous state space. So you have a belief vector. So that introduces some additional complexities in terms of how you solve the problems. But ultimately, you're solving a system of optimality equations where you're trying to take actions that are going to maximize, some immediate rewards you get, plus some expected value to go. And I'll just show you an example, just briefly, out of a paper that covers that POMDP model in some level of detail. It's a recent paper with Wei-Yu Lee, one of my past PhD students now at Amazon. And what he did for part of his dissertation was to look at the most well-known studies for which there was substantial longitudinal data. So there's a study from Johns Hopkins, University of California at San Francisco, University of Toronto. So all American studies. These are some of the earliest ones that were started. And then PRIUS is the most well-known European study. And guess what? When you formulate these models and solve them, you get different results. And what's frustrating is it's not clear why. The differences could be genetic, they could be environmental, could be something to do with the mode of healthcare delivery in the different systems. But I would argue at least being aware of the ambiguity is a very important thing. So we have a region here. So, you can see on the left, the belief the patient's in the high risk group. If it's above 0.4, if we're looking at age 52, for example, it's clear, do a biopsy. Every model says that, we can be confident. If it's below, 0.28, then deferring biopsy, all models agree. But what you do in this ambiguous region is a little bit unclear. Okay, so this is the gray area that's very tough one to make a decision about whether to do a biopsy or not. And so I'll just plug a couple papers by Lauren Steimley, Georgia Tech. This was part of her dissertation work, and she looked at situations like this where you have multiple models, any of which might be the truth, and she looked at ways to try to resolve that ambiguity. I know you, Ding, will be happy that I'm also plugging two papers that are in IISE transactions, and we're very happy to be able to place them there. So if you want to learn more about that in the MDP context, that's a good source. And then there's a forthcoming study from Wei-Yu Lee that's looking at attempting to resolve this ambiguity in the case of partially observable MDPs. Lauren's work was in the area of fully observable MDPs. Wei-Yu was looking at the partially observable context, which is quite different. Yeah, so watching time here, I'll just put in a quick plug for the model-free approaches that are out there. This is very exciting stuff. If you haven't heard of SMART trials, and if you're interested in reinforcement learning, for example, I really recommend looking into these. This is early work that Susan Murphy did, and the basic idea is that you have a sequential multiple assignment randomized trial, so multiple stages and decision rules that are guiding some decisions about how to allocate patients to different treatment interventions or behavioral interventions over time. So these are a couple of papers that are good areas to start with. The second paper here actually describes an approach that uses Q-learning to try to adaptively optimize the adaptive interventions or optimize the decision rules using this common reinforcement learning approach. And this is a literature that's exploding. If you Google SMART trials, you'll find some websites that describe some of what's happening. It's been implemented, in practice, very, very exciting in my opinion, and a ripe area for some of those of you who are interested in sequential decision making to potentially make some impact. So I'll just move very quickly through this and rely on the paper to so I leave a bit of time for Q&A. But the role of human behavior, I would say that's not very well studied. It's not something that comes up regularly in IEOR type studies. There certainly are exceptions, but human behavior, if you really care about having an impact, I mean, the behavioral aspect of things is incredibly important. And we saw that with COVID. It's not enough to create a vaccine. Of course, that's remarkable to create a vaccine or the logistics to get a vaccine, into a region. I mean, those are really tough problems. But if people don't trust the vaccine, aren't comfortable getting it, and you're not solving that last mile problem, so to speak, then, from a big picture perspective, are really not having impact. So human behavior, I think of this as a big new frontier for our field, or maybe not new, because many people have been working on it, but it's still at a very nascent stage. So thinking about IEOR models and how we can integrate human behavior into them to have something more realistic that reflects how people are actually making decisions, I think is a very exciting topic area. And so I was going to talk about an example around medication adherence. I won't do that, but this is just one example that uses a Markov decision process to try to incorporate information about patient adherence or lack thereof to medications like statins, which are remarkable. I mean, the impact they can have is incredible, but more than half the people who start them aren't taking them anymore after 5 years. And so they only work if you take them. And so that's a plug for that. These are some of the other topic areas I mentioned. Just in the interest of time, I'll just plug, disparities for underrepresented and at-risk groups. I think this is an incredibly important area. It's very tough. These are groups where often, there isn't very much data. A lot of these people may be uninsured, and so are getting left behind more and more, day by day, because, it's difficult to explore some of these challenges because of the lack of data. And so I think this is something that I believe every problem's got a solution, and I certainly think it would be a laudable goal to do more studies in this area. And this is an area that I'm starting to work in myself. Okay, so takeaways, I guess that was a lot, I know, to ingest, but I guess there's two takeaways. I think that, at the intersection of IE and OR and data analytics, there's a lot of opportunity to improve medical decision making, but it's a two-way street. These challenges or problems create opportunities for us to develop methods and models that can have impact, and so it's good for our field as well. Many things could have impact well beyond medicine, for example. And then, for those of you who are earlier career or at any stage of your career and are interested, there's so many unexplored opportunities out there. You could be the world's leading expert on the use of IE OR methods for diseases. I'll use thyroid cancer as an example. I'm not aware of anybody who's been working on that area. So I bet it'll be very different, in 20 years, 100 years. But right now, it's just, it's wide open with a really bright future. So thanks to you, Dang, and some of my students who've helped me a lot with the paper, and some of the collaborators and those who have supported this. And again, if you want to find those slides, you can find them on my website. You can also find pictures from me fishing, which I consider the ultimate in sequential decision-making under uncertainty, and reach out if you want, copy of the paper if you want to learn more. And then with that, I'll say thank you and take any questions that anyone has.